picture, for just a second, the exact moment a baby is born.
Oh, yeah. It is a wildly intense moment.
Right. It is this incredibly chaotic, overwhelming, and, beautifully violent second in time. The umbilical cord is clamped, and instantly, like in the blink of an eye, that brand new human loses its entire maternal life support system.
It's all gone.
Oh!
Every single thing they've relied on for oxygen, for metabolic nutrients, for temperature regulation, just gone.
Exactly. And that sudden, absolute loss is exactly why we are dedicating this deep dive to exploring the fascinating, highly choreographed medical science that takes place in those hours and days right after birth.
Because, it really is the most traumatic physiological transition a mammalian body will ever endure. You go from this fluid-filled, temperature-controlled, basically hypoxic environment to a dry, cold, gravity-heavy world.
Where your own organs suddenly have to wake up and take over all the work of the placenta.
Right. And the margins for error in that transition are just razor thin.
So, whether you are, say, a medical professional refining your neonatal assessment skills, or a parent trying to make sense of the hospital whirlwind, or just someone fascinated by human biology, we are going to look under the hood today.
Using some really incredible insights from Patricia A. Scott's comprehensive text on nursing care of the newborn.
Yes, exactly. We're breaking down the biological logic behind everything from the sheer geometric precision of the newborn heel stick to the photochemical reactions happening under those sci-fi looking blue hospital lights.
It's a lot of ground to cover.
It is. Okay, let's unpack this, starting with the very first system check every single human takes.
You're referring to the APGAR score, which happens at precisely 1 minute and 5 minutes after birth?
Right, the APGAR. I like to think of it as like a rapid hardware diagnostic run by an IT professional.
That's actually a great way to look at it.
Because imagine you're booting up a highly complex, brand new server rack for the very first time. You aren't checking if the software is fully optimized or if it can run complex predictive algorithms yet.
No, you just need to know if the thing turns on.
Exactly. Is the motherboard receiving power? Are the cooling fans spinning? Are the basic input-output systems communicating? So you're checking heart rate, respiratory effort, muscle tone, reflex, irritability, and color.
It's a really solid framework. But, unlike a computer diagnostic that just spits out binary data, the APGAR relies heavily on the subjective clinical eye of the practitioner. We really have to ground this in the why.
Right, because there's a lot of misunderstanding around what that score actually means.
Oh, absolutely. A lot of people operate under this misconception that a perfect APGAR score predicts robust, long-term neurologic outcomes, or that a lower score means cognitive deficits later in life.
Which it doesn't, right?
It absolutely does not. It strictly measures the immediate physiological tolerance to the extrauterine environment. It's basically answering one binary question. Is this cardiovascular and respiratory system transitioning autonomously, or do we need to initiate positive pressure ventilation right this second?
Wow. Okay, and reading that physical state requires an incredibly nuanced clinical eye. Let's look at that final metric you mentioned, assessing color. Because if you're assessing for cyanosis or blueness, you can't just look at a newborn's chest or hands and make a definitive call on their oxygen levels.
Exactly. Because, acrocyanosis, which is the bluish discoloration of the hands and feet, is entirely normal in the first 24 hours.
It's just from the cold delivery room, right?
Yeah, it's just peripheral vasoconstriction. The body is pulling blood to the core. But central cyanosis, which indicates a dangerous lack of systemic oxygenation, is much harder to assess visually, especially, across diverse ethnic origins and different melanin levels.
Which is why the standard protocol ignores the external skin layer altogether. You actually have to check the buccal mucosa.
Yes, the inside of the mouth, the oral mucous membranes. Inspecting the buccal mucosa gives you a direct, unfiltered read on the central capillary beds.
Because it doesn't have the external pigmentation.
Right. It lacks significant pigmentation, so the mucosa will accurately reflect the true arterial oxygen saturation long before you can get a reliable pulse oximeter reading on a wet, thrashing newborn's hand.
That makes total sense.
Yeah.
But while the APGAR gives you an immediate read on minute 1, it doesn't tell you the whole story about the internal hardware.
No, it really doesn't.
To truly understand a newborn's invisible vulnerabilities, You have to verify exactly how much time they spent gestating.
And that is crucial because estimated due dates based on maternal cycles are notoriously unreliable.
They can be off by weeks.
Exactly. That's why we utilize the new Ballard score. It's an assessment of neuromuscular and physical maturity that lets you calculate the exact gestational age based purely on how the infant's anatomy has developed.
See, this is where neonatal biology gets fascinating to me. You're reading physical traits to essentially map a hidden timeline, like testing the square window, which is the flexibility of the wrist.
Right, the square window. So if you bend the hand down toward the inner forearm, a premature infant's wrist will only bend so far. It stops.
But a full-term infant is different.
Completely. A full-term infant's hand will fold completely flat against the forearm, looking like a literal square window. And this happens because maternal relaxin, the hormone that loosens the mother's pelvic ligaments for birth, actually crosses the placenta in heavy doses during the final weeks of the third trimester.
Oh, wow. So it causes profound joint laxity in the baby, too.
Exactly. You're also checking their resting posture and arm recoil.
Because of how muscle tone develops.
Right. Flexor muscle tone develops in a very specific caudocephalid progression, which means from the lower extremities up to the head.
So the legs get strong before the arms do.
Yeah. So a 34-weeker might have flexed frog-like legs but completely flaccid arms, whereas a 40-weeker naturally pulls all four limbs tightly into a fetal tuck. And they snap them back instantly if you try to pull them straight.
Okay, I have to push back on this intensive timeline mapping, though. Let's play devil's advocate. If you're assessing a baby born at, say, 36 weeks, and they weigh 7.5 pounds, they have excellent muscle tone and a stellar APGAR score. I mean, they look like a completely normal, healthy, full-term baby. Why are we placing them in a different risk category?
Well, this brings us to one of the most treacherous clinical traps in neonatal care. We call them the great imposters.
The great imposters, meaning late preterm infants masquerading as full-term.
Precisely. A baby born between 34 weeks and 36 and 6/7 weeks might have the subcutaneous fat and the physical bulk of a full-term 40-weeker. But structurally and metabolically, they are radically unequipped.
So you really cannot judge their internal organ maturity by their birth weight.
You cannot, because their invisible vulnerabilities are massive. You're looking at an infant whose hepatic glycogen stores haven't been fully laid down yet.
Which means what for the baby?
It leaves them highly susceptible to profound hypoglycemia, low blood sugar, the minute the umbilical glucose supply is cut off. Plus, they have inadequate brown fat deposits, which severely compromises their ability to generate heat without shivering, leading to rapid hypothermia.
And there's a huge risk of respiratory distress, right? Even if their lungs look fully sized on an X-ray.
Oh, absolutely. They might have just enough surfactant to keep the air sacs from collapsing, but the actual structural compliance of the lung tissue is totally borderline. They have to work twice as hard just to keep breathing normally, and they fatigue very quickly.
Wow. So whether a baby is a great imposter fighting off those invisible metabolic gaps or a perfectly mature 40-week infant, the physiological shock of the outside world is universal.
It hits every single one of them.
And because of those gaps, modern medicine deploys a standard suite of protective interventions in the very first hours of life.
Yes, it is essentially a prophylactic shield. The transition isn't just about initiating respiration. It's about artificially bridging the physiological gaps until the newborn's own systems can catch up.
Okay, here's where it gets really interesting. I want to talk about the precise mechanics of that routine armor, like the injections and the drops that happen shortly after birth.
The standard protocols, yeah.
Let's start with the intramuscular vitamin K injection. Why are we instantly overriding the baby's natural clotting cascade?
Well, because we have to compensate for a sterile gastrointestinal tract. In a mature system, your liver synthesizes essential clotting factors, specifically factors 2, 7, 9, and 10.
But to synthesize those factors, the liver requires a steady supply of vitamin K.
Right, which we adults naturally get from the bacterial flora metabolizing in our gut. But a newborn's gut is a total blank slate.
Yeah.
It's completely sterile at birth.
Oh, right, they haven't eaten anything yet.
Exactly. It takes about a week of feeding to introduce and cultivate the intestinal microbiome necessary to produce their own vitamin K. And during that week, they are uniquely vulnerable to vitamin K deficiency bleeding.
Which can cause spontaneous, catastrophic brain bleeds.
Yes, intracranial hemorrhaging. It's terrifying. The intramuscular injection bridges that exact temporal gap so they don't bleed out.
And you can't just inject that anywhere, can you? I know the anatomical placement is highly restricted. It has to go strictly in the vastus lateralis, the large muscle on the outer aspect of the thigh.
Never, ever in the gluteal muscle. If you look at neonatal anatomy, the gluteus maximus is very underdeveloped, and the sciatic nerve is proportionally massive and sits dangerously close to the surface.
So a shot in the rear could actually hit the nerve.
Yes, a gluteal injection carries a very high risk of striking that nerve and causing permanent paralysis of the lower leg.
Man, the precision is just wild. Now, transitioning from systemic internal protections, we also have localized external defenses. Usually within the first hour, you'll see erythromycin ointment applied directly into the baby's eyes.
Yeah, the eye prophylaxis. This targets a very specific intrapartum threat, which is ophthalmia neonatorum.
Right, which is a severe form of purulent conjunctivitis caused by exposure as the baby passes through the vaginal canal, specifically exposure to gonorrhea.
Yes, Neisseria gonorrhea. And people might wonder why we do it universally. The thing is, even with robust prenatal screening protocols, asymptomatic maternal infections can and do slip through.
And the cost of missing it is huge.
It's irreversible corneal ulceration and permanent blindness. So the localized antibiotic ointment is just a non-negotiable prophylactic barrier.
Speaking of localized interventions, let's talk about the heel stick. This is the universal blood draw for metabolic screenings and glucose checks. From an outsider's perspective, it just looks like a quick prick on the foot, but the anatomical precision required here is, well, it's staggering.
It has to be. You are operating in a microscopic workspace. The puncture must be made strictly on the lateral or medial plantar surface of the heel, so the outer or inner aspect, never the middle.
And the mechanical lance they use is universally calibrated to penetrate no deeper than 2.4 millimeters in a term infant. Why that strict 2.4 millimeter limit?
Because in a newborn, the distance from the skin surface through the fat pad to the calcaneus bone is incredibly shallow. If you puncture dead center on the heel, or if you go even a fraction deeper than 2.4 millimeters, you risk piercing the membrane around the bone.
Which would introduce bacteria directly into the bone tissue.
Exactly, resulting in necrotizing osteochondritis. It is a devastating bone infection that can destroy the heel bone and permanently alter the child's mechanical ability to walk.
Wow. And you stay on the outer edges to avoid the main arteries and nerves too, right?
Right, the posterior tibial artery and the major plantar nerves run right down the middle.
So if we look at this lineup, we have an intramuscular needle in the vastus lateralis, a 2.4 millimeter lance into the heel, and antibiotic ointment forced into the eyes. We have to acknowledge the obvious here. These necessary interventions induce trauma.
They absolutely do.
And this raises a profound question about how a brand new human nervous system actually processes pain.
What's fascinating here is that to understand modern neonatal pain management, you really have to acknowledge a deeply flawed era of medical history. For decades, the prevailing clinical dogma was that newborns were essentially incapable of experiencing true pain.
Wait, really? They thought babies couldn't feel it?
Yes. The assumption was that their myelin sheaths, the insulation around the nerves, were too underdeveloped to transmit pain signals effectively.
Or they thought the cerebral cortex was too immature to actually perceive or remember the trauma.
Exactly. But we now know the exact opposite is true. The peripheral and central pain pathways are completely active very early in gestation. But more importantly, the descending inhibitory pathways, the neurological dampening system that adults use to modulate and suppress pain signals, those are not fully functional at birth.
So they feel the raw data of the pain, but they literally don't have the neurological brakes to slow the signal down.
Precisely. Because of that, the metabolic and hormonal cascade in a newborn, the massive dump of cortisol, catecholamines, and glucagon, is actually of a significantly greater magnitude than it is in an adult experiencing a similar tissue injury.
The physiological toll is immense. But because a newborn can't verbalize, you have to read their facial anatomy to gauge the severity of the pain. You aren't just looking for a crying baby, you're looking for very specific muscular contractions, right?
Yes. A newborn experiencing acute procedural pain will exhibit a deepened nasolabial furrow. Those are the lines pulling tight from the edge of the nose down to the corners of the mouth.
Okay, so deep lines around the mouth.
And you will see a taut, quivering tongue. And the mouth itself won't just be open in a standard cry. The muscles will stretch it into a distinct, rigid, squarish shape.
So, if a nurse sees that squarish mouth and tightened furrow during a heel stick, how do we mitigate it without resorting to, heavy pharmacology.
Mhm.
I actually love the concept of non-pharmacologic pain management here because you are essentially hacking the infant's sensory inputs to intercept the pain signals before they dominate the brain.
It's a brilliant application of the gate control theory of pain. Basically, if you flood the peripheral nervous system with competing positive tactile and gustatory sensations, you can effectively close the gate on the pain signals traveling up the spinal cord.
Like administering a 12 to 25% oral sucrose solution.
Exactly, the sugar water.
If you give the infant a few drops of that concentrated sugar water a couple of minutes before the lance and pair it with a pacifier for non-nutritive sucking, you trigger a massive release of their own endogenous opioids.
And the brain just gets completely occupied.
Right. The brain becomes so consumed with processing the intense sweet taste and the rhythmic motor function of sucking that the pain response is actively blunted.
It is incredibly effective for transient procedural pain.
Now, I have to bring up another universally recognized soothing technique: swaddling. If you've ever watched a newborn, you've probably seen parents wrapping them up tightly, pinning their arms to their chest, and pulling their legs straight down to mimic the compression of the womb. And it instantly calms them down, right?
Well, it does calm them, yes.
Yeah.
But pulling the legs straight down is actually a severe anatomical hazard.
Wait, really? How does straightening their legs cause harm?
So while the upper body restriction nicely mimics the uterine boundary, forcing a newborn's legs into strict extension actually subverts their pelvic anatomy. It dramatically increases the risk of developmental dysplasia of the hip, or DDAs.
Oh, because the joints aren't formed yet.
Right. A newborn's hip socket is highly cartilaginous and relatively shallow at birth. If you swaddle an infant with their hips and knees locked in forced extension, you create this levering force that literally pulls the head of the femur right out of that shallow socket.
Ouch.
Yeah, it leads to chronic dislocation and malformation.
So the hips have to remain in slight flexion and abduction.
Exactly. The legs need to be bent and splayed out slightly, kind of like a frog. The knees must always have the freedom to flex inside the blanket.
Okay, good to know. So swaddling, when done correctly, is phenomenal for comforting an infant. But certain metabolic crises require stripping the baby entirely bare, unswaddled, and placing them in what looks like an incubation chamber bathed in intense blue light. Let's talk about the mechanics of hyperbilirubinemia and phototherapy.
Ah, yes. We're looking at jaundice here, which is the systemic accumulation of unconjugated bilirubin.
Which is a toxic, fat-soluble byproduct of red blood cell breakdown. Now, physiologic jaundice is incredibly common, right? Because a newborn's liver is chemically immature and simply can't process the bilirubin fast enough for excretion.
Very common. It happens in most babies to some degree.
But when the accumulation crosses the threshold into pathologic jaundice, the bilirubin can cross the blood-brain barrier and cause irreversible brain damage. That's when you deploy the blue lights. But how does shining a light on the skin fix a liver processing error?
It's pure photochemistry, which is amazing. The infant is placed under specific fluorescent or LED lights that emit wavelengths between 460 and 490 nanometers.
So it's not just a colored bulb.
No, it's a very specific energy output. And when that blue light energy penetrates the skin capillaries, it physically collides with the unconjugated bilirubin molecules.
It's not heating the molecule up, though, right? It's actively altering its geometry.
Yes. It triggers a process called photosomerization. The light energy actually breaks down the internal hydrogen bonds of the bilirubin, structurally reconfiguring it into an isomer called lumirubin.
Lumirubin, okay.
And the brilliance of lumirubin is that it is entirely water-soluble.
Meaning the body no longer needs the liver to conjugate it.
Precisely. The lumirubin bypasses hepatic processing entirely and is excreted directly into the bile and urine. You are effectively using a light to perform the liver's job externally.
That is astounding. But, because you are dealing with intense, high-energy wavelengths, the safety parameters have to be rigid. I know you have to place completely opaque, solid eye masks over the infant.
Because continuous exposure to that specific nanometer range will cause permanent retinal degradation. You have to protect the eyes.
And there is a strict prohibition on applying any topical lotions or ointments to the infant's skin while under the lights. Why is that?
Well, many commercial lotions contain lipid or petroleum bases. Under the sustained intensity of the phototherapy banks, those ointments act as thermal conductors.
Oh, like baby oil in the sun?
Basically, yes. They trap the heat and cause severe blistering burns across the infant's fragile skin. They must be completely bare under the lights, wearing absolutely nothing but a diaper to protect the gonads.
Wow. So eventually, the bilirubin drops, the phototherapy is discontinued, the core temperature stabilizes, and the blood glucose holds steady. The hospital's intensive medical scaffolding is slowly dismantled. And this brings us to the final and arguably most precarious phase of neonatal care, the handoff.
Right. If we connect this to the bigger picture, the ultimate objective of neonatal nursing isn't simply the physiological stabilization of the infant. It is the comprehensive education of the parents.
Because they have to take this baby home.
Exactly. You are transitioning a highly vulnerable organism from an aggressively monitored clinical environment to an entirely unmonitored home.
And a major part of that transition is teaching parents how to read the infant's neurological states. I think one of the most fascinating concepts in the source text is identifying the newborn zones, specifically differentiating between states of sleep.
Oh, it is a massive source of parental anxiety. Parents often assume that if a baby is moving, they must be waking up.
But the architecture of newborn sleep is totally different from an adult's. You have still or deep sleep, where the baby is profoundly motionless with deep, regular breathing.
Right.
But then you have active or light sleep, which is the neonatal equivalent of REM sleep. In active sleep, their limbs might jerk, they might grimace, make sucking motions, and their eyes might even flutter open briefly.
Which looks exactly like a baby waking up. But neurologically, they are still asleep, and this active sleep phase is critical for synaptogenesis and neural pathway development.
So their brains are literally wiring themselves in this state.
Yes. And if a parent misinterprets those wiggles as wakefulness and picks the infant up, they interrupt the vital neurodevelopmental process. Teaching parents to simply step back, observe, and wait during active sleep prevents both parental exhaustion and neurological disruption for the infant.
Beyond sleep architecture, the discharge protocols dictate incredibly strict biomechanical parameters for home safety. Let's look at car seats, for example. Obviously, they must be rear-facing, but the precise angle of the seat is non-negotiable. Exactly 45 degrees.
It has to be. If you consider the anatomy, a newborn's head is disproportionately heavy, their neck muscles are weak, and their tracheal cartilage is incredibly soft.
Like a wet paper straw?
Right. If the seat is too upright, the heavy head flops forward, kinking the trachea like a garden hose and causing silent mechanical asphyxiation. 45 degrees uses gravity to keep the airway totally open.
And the harness retainer clip must sit strictly at armpit level, resting over the solid sternum rather than down over the abdomen.
Right, because if it's over the soft belly, sudden crash forces could easily rupture the unprotected liver.
Moving to safe sleep environments. The infant must be placed supine flat on their back on a firm mattress to prevent pooling of carbon dioxide. But, intriguingly, introducing a simple pacifier at sleep onset drastically reduces the risk of sudden infant death syndrome, or SIDs.
It's so simple, but it saves lives. And it comes down to airway mechanics again.
How so?
The continuous rhythmic motion of non-nutritive sucking on the pacifier activates the genioglossus muscle in the mouth. This pulls the tongue forward and physically prevents it from falling back and blocking the airway.
Oh, wow.
Yeah, plus it prevents the infant from dropping into an abnormally deep, unarousable, autonomic sleep state.
That is fascinating. Even standard hygiene is completely reframed when you bring a baby home. We assume daily bathing is necessary, but the protocol strictly limits immersion baths to 2 or 3 times a week, keeping the water precisely between 38 and 40 degrees Celsius.
Because frequent bathing actually destroys the skin's acid mantle.
The acid mantle.
Yeah. A newborn's outer layer of skin is protected by a slightly acidic layer, usually around a pH of 5.5, that has natural antimicrobial properties. Scrubbing them daily with regular alkaline soaks strips away those essential lipids, basically breaking down their primary defense against environmental pathogens.
So what does this all mean? When you step back and view this entirely objectively, the journey of the newborn is just a physiological marvel.
It really is.
They survive a violently abrupt transition from a placental life support system to autonomous existence. They endure invasive, tissue-altering medical interventions that temporarily bridge their metabolic gaps. And they rely completely on precisely calibrated external variables, the exact chemical structure of a vitamin, the precise nanometer wavelength of a blue light, the exact 45-degree angle of a chair, just to survive their first week on Earth.
It is the ultimate tightrope walk. And it leaves me with a final thought to consider for everyone listening. We've established that a newborn lacks the descending inhibitory pathways to dampen pain, meaning their hormonal and stress responses to trauma are significantly more explosive than in adults.
Right, the massive cortisol dumps.
Exactly. We also know their developing brain is aggressively wiring itself based on early sensory input. So if their very first interactions with the outside world involve the intense nociceptive spikes of heel sticks, intramuscular injections, and forced environmental transitions, how might that necessary life-saving medical trauma permanently alter the baseline calibration of their HPA axis?
Oh, wow.
Yeah. How does the pain of day one subtly shape the lifelong stress architecture of the human being?
That is a brilliant and honestly slightly terrifying question, and the exact right place to leave this exploration. We have traced the hidden biological mechanics of the newborn transition today, from the first Avgar breath to the precise biochemistry of the nursery. Thank you for joining us on this deep dive. Keep questioning the mechanics of the world around you and stay curious.